You say to a family, oh, it's okay, you can start peanut any time. It's not quite the same as saying you really need to start it now and continue to give it on a regular basis when they have that label of food allergy. But the parent immediately thinks that their child is now a ticking time bomb. And now that family that was afraid to go to restaurants, afraid to travel, afraid to go to birthday parties, can have a lot more confidence. They can feel a lot more empowered to live a much more normal life. The younger, the better for both safety and benefit in the long run.
This is the Transformational Life Consulting Podcast with Deepa Grandin, MD, where Christians like you get the practical support and tools you need to build your spiritual, mental, and physical well-being, and to guide you on your journey to health and wholeness based on evidence-based science and God's Word. I am your host, Dr. Deepa Grandin. I'd like to welcome all our first-time listeners to the Time to Transform podcast. We are delighted to have you join us, and we hope you find this podcast helpful on your health and wellness journey. Now, if you do find our podcast useful, please take a moment to like and write a review as well as subscribe, because once you subscribe, then you can always get the latest podcast as soon as it's published every 2 weeks. All right, so let's get to today's podcast. So the title for today's podcast is Early Introduction of Allergenic Food and the Role of Oral Immunotherapy in Mitigating Food Allergy Perils in High-Risk Infants. Now, I think most of us, as long as we've been paying attention, or if we have children or children that go to school, one thing we might have realized or recognized is the increasing prevalence of food allergies, and this is happening worldwide. And it is becoming a growing public health dilemma, and it seems to be prominent, especially in westernized cultures. So what exactly is food allergy? Food allergy is a common, potentially life-threatening condition that usually begins in early childhood. And often, depending on the type of food causing the allergy and various host factors, food allergy can persist throughout an individual's lifetime. So, as you can imagine, if you have a child with food allergies, or you have a relative or somebody in your community, you know how much of an impact food allergy diagnosis can have. It can lead to negative physical and mental health consequences for a child and their family. So children who are considered at high risk of developing food allergies, especially those who already have one or two, then they are more at risk for more, or they have severe eczema. These are the children we consider high risk. And now there is evidence for early introduction of allergenic food, and in particular, peanut and egg. We have robust evidence, especially since the landmark paper, The Learning Early About Peanut, or LEAP study, was published in 2015. So these high risk infants, the consensus is quite clear that not only should such foods not be delayed, but they should be introduced at approximately 4 to 6 months of age in order to minimize the risk of food allergy development. Now, once an infant or child has an established diagnosis of food allergies, historically it used to be the common management was strict dietary avoidance of the allergenic food and carrying around an injectable form of epinephrine to treat potential reactions. However, more and more we are also getting to recognize the more avoidance that we put on our patients, actually the greater the immunological reaction they may have with accidental exposure. And we also have a lot of discussion and evaluation of what we now call early oral immunotherapy. And this has been shown to induce what we call immune tolerance. And really, the whole purpose behind it is not so much to cure the food allergy, but say the child is exposed accidentally to the allergen and the reaction is not as severe. A 2013 systematic review and meta-analysis actually identified 21 randomized control trials from as early as 2003 that met their criteria for inclusion, concluding that strong evidence exists that orally administered immunotherapy can induce immunomodulatory changes and thereby promote desensitization. So all that means is it changes the way the individual's immune system reacts to the food when they are exposed to it consistently. So as you can imagine, this is a very complex subject. So I'm very privileged and honored to have Dr. Stuart Carr because this is something he does on a day-to-day basis. Most of you are familiar with Dr. Carr. He is no stranger to Time to Transform podcast. He's been here many times prior. So Dr. Carr has been the Chief Medical Officer at Snö Asthma and Allergy in Abu Dhabi since January 2019. And having spent his previous 20 years in academic clinical allergy practice in Edmonton, Canada, he was an associate clinical professor at the University of Alberta, a past president of the Canadian Society of Allergy and Clinical Immunology, and he's also a reviewer for Allergy, Asthma, and Clinical Immunology, the Journal of the Clinical Society of Allergy and Clinical Immunology. So his main interests are pediatric asthma, food allergies, and eosinophilic esophagitis. Dr. Carr is also involved in a Canada-wide collaboration examining the safety and effectiveness of oral immunotherapy for peanut and other food allergies in preschool children. So I cannot think of a more ideal person to talk to regarding this topic. So welcome to the podcast, Dr. Stuart Carr. Thank you for taking the time to share your expertise with us. So, Dr. Carr, you have over 20 years of experience providing allergy and asthma services in Canada and the UAE. Why do early food challenges and food introduction remain one of your main passions in the diagnosis and treatment of food allergies?
Well, thanks, Dr. Deepa, for inviting me and having me back on the podcast. And, I always love the opportunity to talk about food allergies and especially the changes over the last decade. As you mentioned, I've been doing this for, frankly, far too long. It feels like I started my training over 30 years ago now. And the changes, especially over the last decade in our sort of approach to both preventing and then managing food allergy have really been really quite stunning and makes me, I guess, kind of excited to be involved in this sort of work because it really is a night and day sort of change. The issues that you brought up already and touched on, the importance of early introduction. I was lucky enough to be in attendance at the 2015 American Academy of Allergy meeting where the LEAP study was first released and the initial data. And we thought this is going to be a groundbreaking change in allergy. And it really was a paradigm shift. The idea that if we could get the foods, the highly allergenic foods in, especially early into kids that were at high risk into their diet, that we could really decrease their risk for developing food allergy. It was a fantastic revelation and really changed the way that we practice. The I guess now 10 years later, a little bit of disappointing part of that is that it hasn't necessarily made as much, excuse my cat, difference yet in the sort of rates of allergy around the world as we might have hoped it would. And part of that is that one, the message still isn't getting out as well or as sort of pervasively as we'd like. One of the questions that I always ask my young patients, if I see babies with eczema, or maybe they've already had a reaction to a food, or even if they've just come as a bit of a precaution because maybe they've got a strong family history of allergy and the family wants to try to make sure they're doing all the right things, I routinely ask my families if anybody has talked to them about this, and by anyone, a pediatrician, their family physician, public health nurse, has anybody had a conversation with them about, the importance of getting certain foods into the diet early, or what they might be able to do to decrease or mitigate the risk of developing food allergy in this child. And I'm always saddened that almost never is the answer yes. And this is even when they're seeing people with some experience or expertise with eczema or food allergy issues. And I'll say, well, did they talk to you about, getting this food going, or when should you try this? And, did they give you any sort of guidance on it? And again, very often that message isn't getting through. And even sometimes I'll have patients where they'll say to me, well, they told me not to delay any longer, that we no longer have to wait till they're a certain arbitrary age to introduce a common allergen, like as you and I both recall too well, we used to do very commonly. But they're not being as proactive. They may be giving them sort of permission to introduce foods or not to delay the introduction of foods, but they're not emphasizing the critical importance of getting those foods in. And that's a really big difference. If you say to a family, oh, it's okay, you can start peanut anytime, it's not quite the same as saying you really need to start it now and continue to give it on a regular basis. And that's, I guess, the second part of this is that even in those families where they have heard about the value of early introduction, a lot of times they aren't getting the message that then it needs to be continued. And so I get lots of families where they say, well, I tried peanut, or I tried egg, or I tried cashew. And then I'll say, okay, and are you continuing it? And in their mind, it was more like a checklist. I've got to get cashew into the diet, or I've got to try peanut, but then they don't continue to give it. And unfortunately, the data is pretty strong that the food has to be given on a regular basis, at least a couple of times a week, to have this benefit. And that can become problematic. I know we're going to spend more time talking about this over time, but it can be challenging to do this well. But I think that's my biggest disappointment, is that the message, here we are 10 years later, still isn't getting out widely. So, I try every patient encounter I get, every encounter with primary care physicians. I was speaking at a pediatric conference just this past weekend, and I was again trying to make that point that we have the power to really influence behavior at an early age, but we have to make sure that message is really clear and strong.
Yeah. And just to that point, I was recently at a talk and a poll was taken, and it was a talk for physicians. And it was actually quite shocking to see that the majority of the physicians, whether they were pediatricians or allergists, that the confidence level either to refer, to do some sort of a evaluation followed by a challenge or immunotherapy, that knowledge base or the confidence to proceed with that was still under 20%. So you're right. And now you're talking about it's 10 years since the LEAP study came out, and it's still not, the message is still not very strong when it comes from the providing physician. So I totally see what you're talking about. So what are some of the negative physical and mental health consequences for a child and their family with a food allergy diagnosis?
Yeah, I think that I don't think we think about this as much as we should. I think this is an excellent question, and I'm glad that you're bringing this up, because I think sometimes we just think, if we say to somebody, oh, you're allergic to this food or that, and we give them sort of maybe a management plan, avoid it, and here's your action plan, that's kind of the end of it, and they go off and they go on their merry way. And I don't think people realize the impact that this diagnosis has, and part of that reinforces why we need to make sure we're being very accurate in our diagnoses, and that giving a false diagnosis actually can cause quite a lot of harm. When patients, or families, I guess I should say, because when we're talking about young children, it probably doesn't really affect the young child a lot directly, although we'll talk about how it then impacts them as they get older when they have that label of food allergy. But the parent immediately thinks that their child is now a ticking time bomb, and a lot of families just think, oh, this means my child is going to die, or at least have a very, very serious kind of reaction. And in one, study from several years ago in Colorado, they asked moms of kids with peanut allergy if they thought it was likely, very likely, unlikely, very unlikely that their child would die from their peanut allergy. And keeping in mind that the odds of a child dying of peanut allergy are infinitesimally small, less than 1 in a million. You're more likely to get hit by lightning in any given year than you are to die from your peanut allergy. But fully 25% of these moms thought it was likely or very likely that their child would actually die from their peanut allergy. And again, while we know that is really not a realistic estimation of the risk, that's what they feel. And so the quality of life impact immediately is, one, my child may die from this. And then two, we're going to be afraid. We're going to get peanut out of our home. We're not going to go to restaurants. We're not going to go to the mall. We're not going to go to birthday parties. I've had patients where they've never been on an airplane. They haven't traveled because of their food allergy. They've never eaten in a restaurant. I've had kids who've been homeschooled purely because the family was afraid to send the kid into an environment that they didn't have as much control over. And I have, again, a great deal of empathy. I try very hard to both empathize with the families in this situation, but then also try to walk them back to a more what I hope to be appropriate and reasonable level of sort of respect for the allergy, but trying not to be so fearful for what is a really manageable condition. But the quality of life impact of a food allergy diagnosis is generally underestimated and underappreciated. And only in the last, several years have there been good sort of publications and research in these areas, and we learn how profound an impact it has. And then if the child sort of grows up in that environment where, the family has a great deal of fear and anxiety and nervousness around this diagnosis, they can't help but inherit some of that. I mean, I've had kids, I'm sure you've seen the same thing over your career. I've had kids who literally will start to cry when we bring out a food that they're being challenged for. They see the food and it triggers such a visceral reaction and so much fear and anxiety. I've had patients that were seeking immunotherapy as a possible management option for their allergy, but they've got so much fear around their food allergy that they're not ready for something like immunotherapy. I've said, oh no, we have much work to do to get to the point where this may now be a good option for you. And these psychological ramifications of this diagnosis are incredible. And that's why, going back to your first question about, food challenges, it's so important to make sure that we have an accurate diagnosis. Otherwise, we're going to be saddling this family with this really fear-inspiring and crippling diagnosis. So in young kids especially, I can't count how many over the years in infants that I've seen who had maybe hives after trying a food like peanut or egg for the first time. And then when we do a formal food challenge and we work hard to keep the food off their skin, they're able to pass a challenge, eat a large amount of the food as long as we keep it off their skin and we kind of mask the irrelevant sensitization that so many babies have. And again, years ago, and this goes back to your recent experience with so many doctors being sort of either uncomfortable or unwilling to look at doing, either food challenges or this sort of management in young children. Years ago, when I would have a baby with a possible food allergy, we would just say, it's really hard to do a food challenge in a baby. They may not eat the food. It's logistically difficult. They can't really tell us what they're experiencing. Let's just wait till they're older and revisit it then. And of course, as you were alluding to earlier, that's the worst thing we can do. The allergy becomes more entrenched, and now we have many fewer options. We didn't appreciate that then. Now we'll do food challenges in 6-month-old babies, 8-month-old babies, 10-month-old babies, things that I never would have considered, a decade or so ago. And shockingly, in a much easier and often very successful fashion. And even when it turns out to be unsuccessful, the empowerment it gives the families that they understand more about the allergy, they know they've got an accurate diagnosis, they understand more about what a reaction looks like, they understand more about how to treat it. And then, of course, we come in with options like immunotherapy. We're not at the end of the road now with this diagnosis. Now we're at the beginning of a different path.
Yeah, very nicely said. So When you are doing a challenge for a baby, because one of the reasons we were not doing it because they couldn't vocalize how they were
Yeah.
feeling. So, what kind of evidence are you looking for during the challenge that tells you, hey, this child is having a reaction?
Yeah,
Just
it's
the hives and everything.
it's a great question. Yes, that was always one of our concerns. They're not going to be able to tell us what's happening, but I will say now, having done countless food challenges in infants, it's not hard to tell if the baby is actually reacting. The first thing we do is we make a really big effort to keep the food off the skin, for a couple of reasons, as you know. So skin exposure is a big route for developing food allergy in the first place, but lots of kids will be sensitized where they have a positive skin or blood test to the food. And if the food touches their skin, they may get hives, they may get swelling. We can see some very impressive skin reactions from contact with food that don't necessarily equate with true clinical hypersensitivity. So the first thing we do in these young babies is we put lots of Vaseline around their mouth and chin area. We try to keep the food off their skin as best we can. And then we feed it to them in a way where we try to we don't necessarily let them, get it all over themselves. We try to spoon feed it to them. But what we're really looking for is overt symptoms, like if they get hives where it didn't touch them, like on their abdomen or elsewhere on their body, if they get choking or vomiting or coughing or gagging. And one of the common things we'll see even before something like vomiting is actually one of the most common reactions that we see in babies. But before that we'll often see them becoming really irritable, really cranky. And often, even though that's a little bit subjective, and I won't necessarily stop a challenge because the baby gets cranky, I will often say to the family, this may be the start of a reaction, and then we're going to watch and see if anything else develops. I had a baby that we were doing a food challenge in earlier this week, and it looked like it was going well. We were a few doses in, and it seemed like we were maybe going to have a successful challenge. Then the baby got very cranky. Mom said, well, maybe he's just tired. Yes, absolutely. Maybe it's a long morning. It's a weird situation for the baby. But I said, but this might be the start of something. And then sure enough, they started breaking out in hives. They ended up vomiting. No problem. We treated them. They were perfectly fine. But the irritability, the real change in what had been a pretty happy baby cooperating with the challenge quite well to suddenly being quite fussy and irritable was a pretty significant sign. The nice thing about doing challenges in babies is that they don't tend to have severe reactions very commonly. So even when they vomit, they're often then very much better right away after they vomit. We give them an antihistamine to treat their skin symptoms that are itchy and uncomfortable, but we don't see a lot of full-blown anaphylaxis in babies. That's actually quite an uncommon reaction in that age group. So they don't have a lot of the cofactors or risk factors that make older kids or adults more likely to have anaphylaxis. So you're dealing with generally healthy babies who aren't on, a lot of medications or things that can influence it. And as long as you do your due diligence and make sure that they're well at the time of the challenge, it actually ends up being a pretty safe process. By the time they're leaving the clinic at the end of the challenge, even when it was unsuccessful, they're fine. They're back to the same baby they were when they came in.
I think that point about making sure the food is not coming in contact with the skin is so important. I cannot tell you how many patients I've had. The mom tried to do home challenges and then in 4 or 5 days starts seeing redness around the mouth and then gets scared, takes to the pediatrician does blood test. The numbers are all over the place and they've decided they're going to stop the food. And if the child is lucky, then they go for a second opinion with a allergist who knows about food allergies. And typically when you repeat the numbers, they're not as high, or even the numbers are very, very different. And when the physician repeats the food allergy, there's no evidence to prove it because the gold standard is always going to be the challenge. So I'm really glad that you brought up that point because it's very common cause for a lot of families to stop foods and then, down the road puts the child in trouble. Now, can you tell us a little bit about oral immunotherapy? I know you've alluded to it. all this time, but can you tell us like the basics of it and what are the important components of doing an oral immunotherapy?
Yeah, it's obviously a very exciting topic and very near and dear to me. I've been doing oral immunotherapy for food allergy now for, I guess, closing in on 20 years. I started to do milk immunotherapy back in Canada in the mid 2000s, when really nobody in the area was doing any oral immunotherapy, and at that time I wasn't really thinking about it for foods like nuts and that at the time. Obviously, allergen immunotherapy has an old history. It's over 120 years old now, and it's a very well-established treatment for environmental allergies, asthma, and allergic rhinitis. And so the theory has always made sense that if we expose somebody to a small and gradually increasing amount of their allergen, we may be able to modify their immune response. The problem with food allergy is it was always felt to be a bit risky, and some early studies in the mid 1990s resulted in some, this was with injection immunotherapy for peanut allergy, resulted in some very serious reactions, and in fact one fatal reaction, and basically kind of ground a lot of it to a halt for a long time. But oral immunotherapy is quite different, kind of following the expansion of sublingual immunotherapy, under the tongue immunotherapy for environmental allergens. It's become increasingly common and popular over the last 30 years. With a much better safety profile than injection or subcutaneous immunotherapy, it sort of flowed that maybe there would be other ways to give food allergens to people in a potentially safer way than the injection variety. And so really starting around, I think you mentioned in your introduction, in the early 2000s, there were some studies out of Europe looking at oral immunotherapy for milk allergy, egg allergy, mostly, really not a lot of other foods initially, and some really interesting teases of data that got me personally excited with this possibility. And I had a few patients, as you know, most patients, young children with milk allergy will outgrow it naturally over time. And we would take advantage of that and just kind of take a wait and see approach. But I had a few patients, as everybody does, who weren't outgrowing the allergy. And I was thinking, well, is there anything else we can do? And we started to see some of this trickle of data coming in. Now, over the last 10 to 15 years, there's been a real explosion in this area. And so really the approach is similar for any food. You confirm a true allergy first. That's always important to make sure we have an accurate diagnosis. And then in a patient who is motivated and otherwise healthy, otherwise a good candidate, you start by giving very small amounts of that food on a daily basis, gradually increasing that amount until we reach a certain predetermined dose. In our sort of group, as you mentioned, in Canada, that's doing this now for quite a number of different food allergens, we're using 300 milligrams as our target dose, 300 milligrams of protein as our target dose for all of the different foods that we treat. Then once we get to that dose, we continue that daily for at least a year, after which we decide if we're now going to do a food challenge or some other strategy to see if that patient's threshold will now allow them to reintroduce the food in their diet. And what we're seeing is that in very young children, especially preschoolers, kids 3 and under, 5 and under, a large percentage of them will pass a food challenge at the end of that year of treatment to a food that, unlike milk, they were much less likely to outgrow naturally. If you look at the prognosis with peanuts, tree nuts, sesame allergy, only 15 to 20% will outgrow the food on their own. And we can get results as high as 80% passing a food challenge at the end of this immunotherapy course. And what we're also seeing is that while many children undergoing oral immunotherapy have mild symptoms, itchy mouth, upset stomach, maybe a bit of hives, it's really uncommon to see severe reactions. So what we're seeing so far in our now many hundreds of patients that we've been following over the years is a really good safety profile and really good clinical outcomes. And even if we can't get the food back into the diet at the end of the process, we can almost always protect the patients against accidental exposures, the desensitization you were alluding to earlier. And if we raise their threshold up to a level of around 1,000 milligrams of protein, which giving 300 a day almost always does, in our studies, about 99% of patients who to achieve that 300 milligram maintenance dosing are protected up to a level of about 1,000 milligrams. Well, that accounts for almost all accidental exposures in the real world. So now that family that was afraid to go to restaurants, afraid to travel, afraid to go to birthday parties can have a lot more confidence. They can feel a lot more empowered to live a much more normal life, knowing that trivial exposures are almost certainly not going to cause a bad reaction for their child.
Wow. Yeah. I mean, that is so powerful when you first discuss the negative mental health consequences for the family and the child. Can imagine that level of safety and how it's just changed their view, and they can travel, they can go to that birthday party, or as the child feels left out socially, makes a huge difference. So what age interval is considered a safe window for introducing OIT?
Yeah, it's a really important question. First, I guess there's probably no age that you would just say right off the bat it's unsafe. There's going to be greater risks the older you are. And, in our sort of original Canadian Allergy Society position paper on oral immunotherapy, we sort of said at that time, this was about 5 or 6 years ago, that it probably wasn't at this time appropriate for adults. But as I'm sure you've seen, a recent study out of the UK showed that in fact, in even adults, they could be safely desensitized to peanut and protected against accidental exposures. And again, the process is going to be a little different, and you're going to be a little more cautious, and the risk for reactions is going to be higher. But I guess I would say that there's no age where it is intrinsically unsafe or no longer a consideration. But the younger you are, the safer it is. So what I always say to my families, especially when I'm seeing babies that have failed early introduction and they've had symptoms and we've maybe done a challenge and we've confirmed they're allergic, is I say the best age to start is right now when you're a baby. The next best age is under age 3. The next best age is under age 5. And then from there, it's always a little bit of diminishing returns and a little bit of more risk every year older you get. So, if we can get these kids in their, preschool, toddler sort of years, if we can't get them in infancy, preschool toddlers is the best time to start. And I often say to my families that are starting immunotherapy in this age range, again, it is a different issue in older kids, but in that preschool age range, the families are very nervous. And I always say to them, really, it's going to be a bit anticlimactic. It's going to be a little boring. The immunotherapy is I had this conversation with a mom today. We did a food challenge on the child for sesame. The child ended up vomiting and showing a pretty clear reaction. And the mom was saying, I guess it'll be a bit like this when we do the immunotherapy. I said, no, the challenge was the risky part. And we're done that now. We've crossed that bridge. The immunotherapy part is actually going to be a little more boring. And that doesn't mean we don't, again, respect it, and we still follow all the same protocols. And even when families say, oh, it's been going so good, can't we just do X, Y, and Z? No. We're going to stick to what we've shown to be safe and effective, and we're going to do it in a cautious, proper way. But most of the time when we get up to our target dose, the family says that was way easier than we thought it was going to be. So the younger, the better for both safety and benefit in the long run.
Yeah. And also, since the approval of Xolair for food allergies, especially with the adolescent and adult population, has been a game changer. For me, even before the FDA approval, and my asthmatics who were on the Xolair, I would be more confident in introducing or, trying to do the immunotolerance with these individuals, and they seem to tolerate it a lot better too. So what are some of the pitfalls of the wait and see approach?
Yeah. So, we've known for a long time that if you don't outgrow a food allergy, it often seems to become worse. And we weren't sure if this was, a reflection of maybe they had a different phenotype, a different kind of the allergy. We see that with milk. If you're not one of the ones who can tolerate extensively heated milk, it sort of says you've got a different phenotype of milk allergy that has a less favorable clinical course, more likely to have bad reactions. But what we are seeing with some of these other foods like peanut, tree nut, sesame, is that the longer you avoid it after you've initially sensitized, after you've initially become allergic, your immune response does change. It seems to evolve in a really disadvantageous way that to start with, you may only respond to one or two peanut proteins. But if you reassess that same patient years later, they now have a much more diverse immune response to the different peanut allergens, which now, again, may increase their risk for reacting at a lower threshold, and then may be associated with more severe reactions. So I think that the line I really took to that really resonated with me was a colleague of ours, Dr. Jonathan Hurricane from Ireland, who made the comment that we have to understand that doing nothing is doing something, that it isn't a passive approach. We used to think of it as, well, we're not intervening, we're being passive, but by being passive, especially with the evidence we now have, we are allowing this immune sort of maturation to occur, and now the immune response becomes more entrenched and much more difficult to deal with. Young children also have the benefit of a more plastic immune response. We can modify it easier the younger they are, and the older they get, the more stubborn, the more, again, entrenched that immune response becomes. So not only does it become harder to manipulate the immune response, but their immune response to the allergen becomes worse, for lack of a better word. So again, trying to intervene earlier rather than this sort of wait and see approach. The other thing that happens, and again, this goes back to your very first question about the psychological impact, is in very young children, while their parents may have some of that psychological burden, the child doesn't yet in most cases.
Right.
And if you can intervene early and you can start giving them a small amount of their food allergen early, they don't have the same aversion and fear of that food that older kids have. If you take a kid who's been avoiding peanut, they've been told it might be very dangerous for them. They have to always ask, they have to make sure they've got their, EpiPen kit with them. And now they're 6, 7, 8, 9 years old, and you're going to try to reintroduce this food into their diet. Even in the kids who outgrow it and pass a challenge, they often aren't interested in eating it. They often hate the food. They're often angry with the food. And in studies of older kids doing immunotherapy, a large percentage, even those who have been successfully desensitized, revert back to avoidance because they really dislike the food and it's a burden psychologically for them to continue to eat it.
Yeah, makes sense. And the other component, which we don't fully understand, is the microbiome, because the younger the child, the more plasticity, like you had mentioned. I was just reading this article on the short chain fatty acids, and I think it was a Preventable species, which is more abundant in kids that don't have food allergies, and somehow doing this type of oral immunotherapy instigates that. And which in turn has a role to play with immune tolerance. So I think there's so much that we're still trying to discover in this whole realm. So who is considered a high-risk infant that would benefit from early food introduction?
Yeah, so that's a really good question, and you alluded to some of this again in your preamble, in which I think it's good to reiterate those points. So I guess first of all babies can benefit from early introduction. So we no longer only recommend giving these foods early in high-risk kids. We really emphasize it in high-risk kids, but there's no reason to delay it. And what we want to is, I mentioned that there's been, here we are 10 years later, there's this inertia where we aren't getting pediatricians and public health nurses and everybody else to just sort of reflexively invite people to start giving these foods early. So I would hope we get to a point where that's the default position. Everybody's eating peanut at 6 months of age, and everybody's getting egg in, and it's no longer this kind of looking at it like, oh, but that's a common allergen. Don't we have to do something special with that? So our hope is that eventually everybody is just eating it. But the ones where it's really critical, as you mentioned, babies with moderate to severe eczema, and there's a real dose response between the amount of eczema and the risk for food allergy. If babies have very mild eczema, their risk is only marginally increased over the general population. But if they have moderate to severe eczema, it is the single biggest risk factor for developing any food allergy. If they have already reacted to some other food, as you mentioned, it makes them more likely to develop other food allergies. And again, I always try to explain to my families that this is, it's a double-edged thing in that it's not a done deal. 90% of kids with food allergy are allergic to one food only. So, we're always optimistic. You're not going to start reacting to other foods. This is important because a lot of families are now scared. They go, oh, but I've reacted to egg. I'm scared now to give other food. Well, no, you're probably going to be fine. And by intervening earlier, giving these foods earlier, you're more likely to be fine than if you kind of, again, err on the side of caution and wait, because that will increase the risk. But if a baby has reacted to some other food, milk, egg, whatever, it only becomes that much more important to start giving these foods. We see this a lot with nut allergy. If a baby has a peanut allergy, I'm always explaining to families that peanuts and tree nuts are not directly related. They don't have any common allergen that makes them cross-reactive. But about a third of kids with a peanut allergy will ultimately become allergic to at least one tree nut, almost entirely because of our behavior, that we end up avoiding them as a precaution. And in doing so, we deprive the child of that beneficial protective exposure. And then because they're predisposed to being an allergic individual, they end up becoming allergic. It becomes like a self-fulfilling prophecy. So if a child has reacted to another food, it only becomes that much more important for us to try to get them to introduce the food early. And while food allergies aren't inherited, and so therefore we shouldn't necessarily look at a family history of food allergy as a risk factor sort of immunologically, it's a risk factor psychologically for the exact same reason I just mentioned, which is if an older child in the family, an older sibling has a cashew allergy, the family is going to be more nervous about introducing cashew with the baby. And in doing so, they may again take this, well, I'm going to wait a little longer. I'm just going to be careful, which is the exact opposite of what we want to do. So I really focus heavily on babies with moderate to severe eczema, babies who have reacted to another food, or babies who have a strong immediate family history of food allergy, to really target that early introduction, because they're the ones who are going to benefit the most.
Yeah. And even with the dual sensitization, the exposure through the skin versus exposure through the gut, the immune training is very different. Like through the skin, they're more prone to being allergic, versus through the gut, it's more tolerance. So,
exactly.
And yeah, the immunotherapy is important. So how many times a week should the allergenic food be given to maintain tolerance?
Yeah, so if we're talking about early introduction, again, the best evidence we have says twice a week seems to be the magic number. So this is not, of course, for treating a food allergy. In that case, we're giving the small dose daily. But now we're talking about a baby who's not allergic. We're trying to get them to benefit from early introduction. And it seems that twice a week is a very effective frequency. The problem with this is the doses that have been confirmed to be protective is about 2 grams of protein twice a week. So that's about the equivalent of 8 peanut kernels, if we're talking about peanut, or about just over a teaspoon, about 1 1/4 teaspoons of peanut butter. And that's not an insignificant amount in a small baby. That's a relatively large amount. And I mentioned already that if you give a baby peanut early, it protects them against peanut allergy, but that doesn't protect them against egg or cashew or fish or sesame. These are all very specific proteins, and your immune response to them all is very separate. So we know that if they eat 2 grams of the allergenic protein twice a week, it is very hard to become allergic if they do that consistently. But, and there's always a but, it's very hard to give all of these different common allergens twice a week consistently starting in early infancy. You can imagine it can become an all-encompassing job for the family to try to give all these foods. And one of the early studies out of Australia, the EAT study and their follow-up study showed that if you do it, it works really well. But a large percentage of their study population, it didn't work because they weren't able to do it. It's just too much. And maybe you can focus on peanut and maybe you can get cashew in, but you're going to end up neglecting sesame or, and if you're really predisposed to be an allergic individual, your immune system will find a way. It'll do that. So it's an achievable outcome, but it's hard. And I have a lot of empathy for the families who try to do it because it's difficult to give these foods as consistently as we want.
Yeah, and I think there have been publications looking at multi-food powder formulations, and they've had some success with that as well. So that would make it easier.
Well, yeah, and this is, again, it's a great comment because I get patients who ask me about some of these products, and the answer is, again, yes, but I mean, these are often quite expensive. I saw one product recently that a patient asked me about, and I wasn't familiar with this particular product, but they sent me a link, and I went to the website and I looked, and I was quite stunned at the cost, and I sort of said, yeah, this would work. It's the right stuff, but it's really expensive. And if you just buy food, it's going to do the job at a lot less cost. But again, it may be difficult to do that. So, for example, with the different nuts, I will always provide my family with this simple recipe for a homemade mixed nut butter. And I'll say to them, if you put almond and hazelnut and walnut and cashew, you're covering the big nuts. If you give peanuts separately, we want to try to make it as family friendly as we can. But yes, it can be a lot of work, but we also don't want it to be so expensive the family needs to take out a second mortgage to prevent allergy.
Yeah, and I have some colleagues, they actually compound them themselves, like they get the individual powders, mix it up and give it to the families. So I think sometimes we have to be, creative and trying to help them comply.
That's what we do for the immunotherapy for sure. Yeah.
So what are some of the implementation barriers? And you've already actually gone into it. If there's something that you haven't gone into that results in difficulty maintaining regular ingestion of food following the early introduction in the real world.
Yeah, I mean, I think one of the big issues, again, it's awareness we've talked about, and a lot of these families aren't getting the education from their primary care physicians. But then second to that, so, I think we've talked a lot about that, but secondary to that, we need to provide them a comfortable way to do this. So, one of the things that we do in our clinic quite commonly is if we have somebody, especially if they've reacted to a previous food, I'll say to the family, I really need you to start getting peanut or sesame or whatever into the diet. And they're understandably nervous about it. We talk about it. I try to reassure them that it's really not likely to be a problem and that they really should feel comfortable doing it. But at the end of the day, they're often still very nervous and uncomfortable trying it on their own. So one of the things I explain to my families is my job in that scenario is whatever it takes to facilitate you getting this food into their diet. If it's a conversation, if it's me reassuring you, maybe in some situations, very selected ones, doing certain tests. But very often what it does entail is you can come into my office anytime, as long as I'm physically there, and feed your child. It's not a formal visit. It's not a food challenge. It's not a structured, regimented thing. It's you giving your child food in a place where you feel comfortable doing it. So when I think it needs to be a structured formal challenge, that's a different thing. That's book very differently, and it's a very structured process. But I have kids all the time coming in, and the family is just introducing a food that they've been uncomfortable introducing at home. And it takes no time out of my day. I might say hello to them. Most of the time, they're just in the waiting room feeding their kid. It's not a burden for me. But we need to be able to provide some of these safe environments for people, because families will say to me, well, when I try this, should I be sitting out in front of the emergency room? And I say, oh my God, no. If I thought that was necessary, I wouldn't let you try it at home. But if you'll feel more comfortable doing it in our waiting room, do it. That's fine. Take some time out of your day and do that. But what I don't want you to do is never try it, and then beyond the early introduction, we need more capacity for food challenges. We need more of our allergy colleagues willing to do food challenges in babies, because again, very often the diagnosis is not accurate without a food challenge.
Yeah. That's such a great, access that you're giving a lot of families, because that psychological component is really, really scary for a lot of families. So what evidence do we have that oral immunotherapy improves quality of life?
Yeah, it's a great question. And this is an area that's evolving. Quality of life measures typically follow after you start doing, safety and efficacy outcomes. And we spent probably the first better part of 5 years in our sort of approach to oral immunotherapy focusing on safety and efficacy. And now we're looking at some of these issues like quality of life and psychological impact and, caregiver quality of life and this secondary kind of outcomes, maybe very important outcomes, but they don't get sort of attention up front. But now there's growing evidence. There was a big study about 5 or 6 years ago that showed even just getting to the target maintenance dose improves quality of life. And then that improvement is maintained over the next sort of 6 to 12 months of continued dosing. And that's because, again, the patients, one, feel a lot more protected against accidental exposures, and two, they feel more empowered that they're proactively doing something about their child's food allergy. They're taking control of the situation instead of letting the allergy control their life. Early on, there were some studies that sort of said that immunotherapy may not improve quality of life, and part of that, I think a lot of that maybe is due to the way that it's sort of spun and the way we set it up with families. If we're not realistic about what side effects might occur, and if we're not realistic about what is achievable with it, especially again in older kids where, they may have a lot of adverse effects, especially mild symptoms like upset stomach and mouth irritation and that. And if you get to a point where, maybe they're protected against accidental exposures, but they can't eat normally, that may not be very satisfying for a lot of families. They say, well, he wasn't really having a lot of accidental exposures. And that's why, especially in older kids, one of the first things I do is I ask them, what is your goal of treatment? And so I know that we can have a realistic conversation about, what we can achieve and what we can't achieve. And that way we're not sort of setting them on a pedestal that is not achievable, and then they walk away disappointed. So a lot of quality of life, I think, measures end up boiling down to, did you set expectations appropriately at the outset? And did you give them a realistic view of what this was going to look like, and then what it achieves and what it doesn't achieve? But in young kids, I had a family just this week that reached their maintenance dosing, and the mom said, I already now just feel so much more comfortable. We're going to travel this summer, and I feel much better about going on the airplane, knowing that he's able to tolerate the amount he's taking now. And so it really does have a very impressive impact on quality of life and confidence.
Yeah, so true. Well, Dr. Stuart, you've shared so much valuable information with all of us. Is there anything else you would like to share with the audience before we conclude?
Yeah, well, first, Dr. Deepa, thanks again for inviting me onto the program. As you can tell, I really enjoy talking about this. It's a topic that's near and dear to me, and I say to families all the time that having practiced for 20 years before we had this sort of approach with early introduction and then oral immunotherapy, and now seeing the way this impacts these similar patients, but being able to be so much more proactive and make a real difference in their outcomes, it's night and day. And so I've been on both sides of that equation, and I'm thrilled with the way that we're trying to address it now. I think the biggest thing I would say is, if your pediatrician or if you're seeing an allergist, if they're not sort of emphasizing the importance of early introduction, if they're not offering or at least discussing food challenges with you after doing testing for food allergy, after evaluating you for possible food allergy, and if they're not at least, again, having a discussion about oral immunotherapy, a lot of allergists may not be able to offer it for a variety of reasons. Logistically, it can be a bit complicated and it takes some experience and some expertise. But if the people that are caring for you and your child with food allergy aren't at least having that conversation with you to talk about even referring you to a center that's offering this, you may need a second opinion. And I hate to say that, but you've got your job as a parent is to look out for your family, and only you can advocate for your family in an optimal way. So if you're not at least having those conversations with whoever's providing care for your child's food allergies, then you need to proactively seek out somebody who is offering a sort of a more modern evidence-based approach to food allergy.
Yep, that's a pretty great ending to this discussion. So thank you, Dr. Stuart, again, and we look forward to having you in future recordings.